Error. Electricity in line. Override accepted. Infusion initiated.
Welcome to the INS Infusion Room, the official podcast of the Infusion Nurses Society. In this podcast, we explore all things infusion therapy through a real-life conversation, covering the latest trends, new research, evolving standards, and key industry insights. Whether you're an experienced infusion nurse or new to the field, we aim to keep you informed and empowered with the knowledge to stay at the forefront of the profession. My name's Derek, and I'm your host. Let's dive in. Hello and welcome to another episode of the INS Infusion Room. Today we have a very special guest, Dr. Marlene Steinheiser in the studio. Welcome, Dr. Steinheiser.
Thank you, Derek. Thanks for having me today.
And for those of you who don't know her, she is the Chief Clinical Officer of INS, and we're very thrilled to have her talk about a follow-up from her session where she opened up INS 2026. If you didn't have an opportunity to see it, we're going to talk a little bit about what she talked about, the impact, and a little follow-up because we've had several of attendees follow up and ask directly how your in-laws were doing. So we thought it'd be a beautiful opportunity to come on the podcast and provide an update, and maybe for those who didn't attend, talk more about the impactful session that you delivered at INS 26. So
Yeah, thanks, Derek. I did have quite a few members, attendees come up to me after the session and ask, a bit more about the incident that happened. And also, can I have a copy of the video? Well, this is a way they can have a copy of the video because we'll, have the video embedded into this podcast. So it'll be a good way for them to have it, plus some of the background information. And so I kind of would like to start with that. I used this scenario that happened with my in-laws, Betty and Phil. And Betty is a 90-year-old and Phil is 97. Actually, my father-in-law, Phil, will be 98 in July. His birthday is 2 days after mine. So pretty soon he will be 98. Just want to give a little background of them. They both lost their spouses in 2008. And they attended the same church and they got to know one another. And it was really kind of adorable. They met each other and soon after decided that Betty said, we need to get married really quickly because we're getting close. And she's very religious and thought that, because they wanted to be closer, that they needed to be married. So they've been married now 15 years. They live in a CCRC, which is a continuum care residential community. And they live in independent living right now. And just recently speaking to social work, actually just about a week ago, they're both kind of deteriorating some actually since the INS meeting in April, but they together are a good unit. My mother-in-law mentally is sharp, physically a little bit in need of help and assistance. My father-in-law is having some cognitive decline, but he is physically sharp and able to move and help her. So together they're a great team. But what ended up happening last September was really kind of a turning point for me. And not only as a clinician, but as a family member, I wanted to do something with their circumstance. And I asked them both if they would be willing to share what happened to them. And they both were. And that's how we ended up doing the video recording. But just to give a background of what happened. So in September of 2025, for a couple of days, my father-in-law, Phil, he said, I couldn't breathe really well when I went to lie down at night. So us as nurses think right away, what's going on? Fluid in the lungs, what's happening? He went for a chest x-ray per his physician order. He came back to his community and the physician said, you need to go to the emergency room, but I want you to go to the cardiac hospital where I have privileges. So he says I can go in the morning. Well, of course, my first reaction is, no, you cannot go in the morning.
not
right?
happening
No, you need to go in this evening.
right now. Yes.
Right now. So I called his apartment and no answer. So I get worried. I'm like, what's happening? So I called the nurses station. They sent security, a nurse down to his apartment. Come to find out, my brother-in-law agreed to take him. He agreed my brother-in-law could take him to the hospital. My husband was out of town. So my brother-in-law starts to perform the transfer of my father-in-law to the emergency department. I'm on the phone with Betty and she's gasping for breath. I could hear her wheezing through the phone. Yeah.
When it rains, it pours.
It does, and I get the nurse on the phone, and the nurse says she goes outside the room, and she said she calls me on her cell, and she said, "Yeah, I think we need to have her assessed." I said, "Yeah, I'm not comfortable her staying home alone." So paramedics come. She needs to be transported to the nearest emergency department. So now we have both of them in separate emergency
Separate.
departments at the
Yes.
same time.
I
So
wanted to emphasize this, separate, and you're
separate,
trying to keep up with both at the same time.
yes. So my brother-in-law takes my father-in-law to the transports him to the one, and I meet the ambulance at the nearest emergency room with Betty. I walk in 20 minutes after Betty arrived, and she already has her peripheral IV catheter placed. So I took a look at it, and you can see in the pictures that she had blood underneath the dressing. Looked like it was oozing from possibly the insertion site, hard to tell without assessing it. And you'll see the photos of the next morning when I saw my father-in-law, and actually after his peripherals were removed. Both of them had peripheral IV catheters inserted, my father-in-law in each arm and my mother-in-law in her one arm. You probably notice in the photo her bracelet, and you'll notice in her photos she is always made up with her makeup and her jewelry, always ready to be presentable. But she showed up to the emergency room with her jewelry on, and you can see that in the photo. So that's really what started this
Yeah.
scenario with me and with them, and really prompted me to want to do something with their story if they were willing, which they have been, to share their story and how it can impact nurses.
So when you first heard about their experience with the IV insertion and care, what struck you the most as a family member and a clinical leader? It's hard to balance the two, I would imagine.
And that's always a challenge. I'll tell you, I have so many different stories with not only my own care in outpatient procedures and my husband's and other family members and friends. And it's hard because I don't want to be in the way of what's happening clinically and allow the nurses and the other clinicians to do their job. But also I want to advocate when I see something, or if I find a teachable moment. There's been times where I've been able to and help instruct new nurses and share what I do know, and share the fact that the INS standards of practice exist so they can access them, and use Ask Ivy to ask questions now. So
Without
when I
being that person, right?
yeah.
I know as healthcare providers, we sometimes kind of shrink in the corner a little bit because we don't want to add the unnecessary expectations or have that stigma behind the care by being another healthcare representative in the room watching. So
Mhm,
it's that fine line that it's hard to balance when you're both a
mhm,
patient advocate with as a clinical leader and a family member.
mhm. Yeah, and I think what I noticed first when I walked in both in the day that I walked in to see Betty 20 minutes after her arrival to the ED, but even the next day when I got to see my father-in-law, which is really only a few hours later because I didn't leave. Betty didn't get home from the hospital until I think 2 or 3 in the morning. I slept a couple of hours and went over to my father-in-law's hospital to check on him. So a few hours later, I saw his peripheral IV catheters. And what was striking in both cases is that neither one of them were told anything about why they were having the peripherals placed. They had no idea why. There was no assessment from their recollection. It was just, here's the antecubital. In my father-in-law's case, it was both sides. In my mother-in-law's case, they just looked at the one and placed it. And then you can see from the photos that there's distinct post-care challenges. My father-in-law's dressings, my mother-in-law had the blood underneath her dressing, which we did find out was actually the extension set was not attached properly to the catheter hub. So she was going for a CT scan with contrast. She would have had contrast dye all over her arm. So I'm glad we caught that. And I kindly asked them to assess that before she went down for that. So I was glad we were able to catch that.
So now that we've heard about your experience and your take, I want to play the clip from their experience. But before we play it, what do you hope listeners really hear and feel in their words?
I think pause for a moment and listen to their patient experience. And although we place peripheral catheters day in and day out, it's a routine practice for us. It's not routine for patients unless they're chronically ill and used to maybe coming into an outpatient center for treatment or therapy. It's not routine. And so For them, it's a huge experience. It's a very impactful experience, and one that they come to fear because they've had negative experiences in the past. So I'd ask clinicians just to pause and think about how this impacts a patient when we place those peripherals. And also, could there have been maybe ageism involved possibly in their case? Because I mentioned, some of their challenges as they're aging. And, is it possible that that could have played into some of the practice that occurred with their peripheral IV catheter insertion and care? When you both went to separate emergency rooms, you both had peripheral IV catheters put in. Can you tell our audience about that experience and what happened when those were placed?
Every time I have a catheter put in, I have the same problem. I have fairly thin skin, and when they put the needle in, it just never quite works right. It tends to bleed. And so in this case, it was bleeding not profusely, but slowly. Betty, do you remember I came into the emergency room about 20 minutes after you got there? What do you remember about that?
It went in my arm, around my elbow, and then it hurt, and then it started bleeding a little bit.
And you were saying it was hurting after it was in, correct? Not just the actual needle stick, but after it was in.
Because it was right where you would bend your arm, it would hurt.
Mhm. Well, Dad, when you were in, I remember I came to visit you the next day and you were saying how it was hurting you. And yours was in the same location, what we call the antecubital fossa. And you had one in each arm, right?
Yes.
Yeah.
Yes, I had two.
Yeah.
But yeah, I think they were pretty much both the same. A small amount of bleeding, like it hadn't been done right. But I'm not that sophisticated with that kind of thing.
Do you remember if the nurses had asked you how it was feeling, or did you have an opportunity to tell them what was happening?
No, I just assumed it was normal.
I remember it hurt, and it was bleeding a little bit. I thought it might be normal.
When you were getting your IVs placed, for either one of your situations, did they tell you anything about why you were having the IV placed or for what reason?
I wasn't getting much information at all.
Yep, the same with me. They implied it was necessary, and they just did it.
It's interesting how you both have said you didn't really know and thought it maybe was normal. You had so much bruising, it was all up and down your arm when you came home, and that lasted for quite a while. And that's really not normal.
I assumed it was subcutaneous bleeding. Again, time and time again, it seems that when they put that needle in, the person who's doing it is relatively inexperienced in doing it. Someone more experienced might have done a better job.
Did you say anything to them about the IVs and how they were bothering you?
No, I did not. My personality is such that I don't complain about stuff like that.
Yeah.
If it has to
Yeah.
happen, it has to happen, and I can accept it.
Well, my personality, I complained. I was hurting.
If you were told when you were having your IVs placed, if you feel pinching or burning or you see it's leaking, please let us know. Would you have said something?
Yes, I would have. I say again, I just assumed it was normal with a person
Yeah.
like with an arm like mine.
What advice would you give nurses based off of your experience? What would you want them to know?
The impression I have is that they do these procedures many times in the
Mhm.
emergency room or the operating room, and that maybe something that could happen is to have one person uh, per shift or something, but some one person who is more expert at particular function rather than any nurse who happens to be around to do it, and therefore doesn't do it frequently enough to
Mhm.
become expert.
Anything else that you want to tell us about those experiences that you had?
The natural one is I wish it hadn't happened. But aside from that, I think somehow, and I know that that's what you're working on, is to get better training and or more experience so that they know when they're doing it the best way.
So let me turn the tables now and ask if you have questions for me.
What do you want to do about this?
How am I going to do it?
So after that moment, your father-in-law asked a powerful question. So what are you going to do about it? How did that question land with you?
Well, first I inside laughed a little because I thought I could not have scripted this for him
No,
any
it
better.
was not
He just,
scripted. We were
it was
both part of
not.
that. No.
It was amazing that he said that. And it was also interesting that, you hear him describe basically a vascular access team or a specialist. Again, never coached him, never told him anything about that, yet he intuitively described, what we could use to help in this practice. But, I think there's two things that we need to consider, and there's two themes. It's education and collaboration. And the first thing you might think of is education, of course, our students, our new graduates, even our experienced nurses on updates to the standards, and collaboration with other clinicians. But it goes beyond that. I really think we need to focus on education for patients and collaboration. And it's stated in the standards clearly. It's really putting it into practice. And I want to share as we move through this conversation some ways that could be maybe simple, but very impactful ways we could implement different practices that could change the experience for patients.
So you used that question to open INS 2026 and challenge the entire audience. What made you decide to bring something so personal onto such a large stage?
Because peripheral IV catheter insertions are the most invasive practice we do in a hospital or in many other care settings worldwide. It is the most prevalent. And so we have, for the most part, nurses place peripheral IV catheters. So as nurses, we have the ability and the opportunity to create great change by impacting the way we perform and the way that we practice. And this could make not only a great impact on patient outcomes, but patient experience. And so it's about both. It's about patient outcomes and patient experience.
So there was also a response board where attendees wrote how they plan to make an impact. What stood out the most from what people shared?
I wrote some notes down. That board was filled. I was really thrilled. And by the way, I showed the video of the board to my in-laws. I had dinner with them shortly after I got back from INS in Wacova, and they were just tickled that they've made such an impact. They had no idea. And I said, "You really have impacted nurses." Nurses came up to me to ask how they were doing, said that they were really touched by their story, that they, really loved to get to know both of them. But what I found from the board was a couple of quotes. Every vein deserves world-class care. I thought that was impactful. And that's standardizing care using evidence-based practice and INS standards. Also in caps was collaboration. And we just talked about collaboration. And there was nothing, put beside that statement. But I think that speaks volumes because we talk about collaboration. We always think of other clinicians, but collaboration with patients and education, advocacy, and one-time sticks. So first-time success with advocacy and education. And, I might have been a little biased when I pulled some of these quotes because they really did resonate with me according to what my message was during that session. But it also was really interesting to see there was such a diversity of statements and really engagement from everyone that attended. So really want to thank everyone who did attend and was able to write something on the board.
So from your perspective, where are we still falling short in infusion therapy? And where do you see the greatest opportunity to change right now?
Well, I think again, going back to the education and collaboration, and it could be education that is delivered in different formats. So, depending on your care setting, the type of nurse, if you're working with new graduates versus experienced nurses, and really looking at how we can deliver that new information. The standards of practice are revised every 3 years, and that's important to make sure that all clinicians are up to date, but also collaboration with our patients so they can help us identify challenges or issues with their peripheral IV catheter insertions and care that's after insertion.
So immediately after INS 26, like that wasn't enough.
Mhm.
You traveled to Valencia, Spain for Wacova. What was it like to carry that same message on a global stage?
And for those that don't know, WACOVA is the World Congress on Vascular Access, and it was really a wonderful experience. During my presentation with other countries who discussed vascular access standards and guidelines, I was able to talk about the INS standards of practice. And it was really humbling to hear from the many other countries how they're implementing the standards and how they need to adapt potentially according to whether it's scope of practice restrictions or environmental or resources or products that they have or don't have available. A couple that stick in my mind is South Africa, for example. In South Africa, nurses cannot place any central vascular access devices, but they have become involved in collaborating with their physicians to impact care. They're able to impact care by determining catheter to vein ratio and really implementing post insertion care in a standardized manner according to the standards. Poland. In Poland, practice and culture is changing rapidly. In Poland, for example, there's a nurse that is focusing on patient-centered care, which we find to be common here in the United States as a theme, but it really isn't common necessarily in other countries. And so we're finding that that's happening in Poland now too. So that's, very interesting. But also was interesting to hear from India and Brazil, some of the changes that have occurred in those countries. China and Taiwan. Taiwan, for example, doesn't have a midline catheter at all available in their country and how they're adapting to what patient care needs based on their product availability.
Yeah, so last season we actually had, Louise Esterhuizen
Mm-hmm.
and Dr. Latos. Louise is from South Africa, and she talked
Mm-hmm.
about those changes, and Dr. Latos is from Poland, and he led a lot of those initiatives. So
Mm-hmm.
for those listening, if you didn't get a chance to
Mm-hmm.
listen or tune into those episodes, I highly encourage you to do so. What impact did you see at Wacova, and how are global conversations shaping the future of infusion therapy?
What I found was that through learning from those leaders in those countries, like you had mentioned, Louise in South Africa and Dr. Latos, Maci Latos in Poland and others, we learn how they're using the standards of practice and evidence to shape care and how they're leading that change. And we all have obstacles, whether it's, if we're in home infusion, we don't have a vascular access team or somebody around the, corner that we can call to say, hey, can you take a look at this, this patient so that I can determine where to place the peripheral IV catheter, or nor maybe do we even have vein visualization readily available. So they're really sharing how they're able to advance practice, understanding the standards and the evidence, and not to say that they're functioning at a different level with the standards. They're applying the standards, but to practice in which that they have resources available. So like I mentioned, Taiwan, they don't have midline catheters. It's interesting to learn from them how they're practicing. And so they basically need to either have a nurse inserted peripheral IV catheter or a central vascular device placed by a physician. And so that really, makes a difference when you're determining plan of care for a patient.
So, looking ahead, what is your vision for INS, and what do you hope every clinician listening today will do differently after hearing this conversation?
That's my favorite question because I think there's a lot we can do, and I believe it can be simple. I believe that next time you go to place a peripheral IV catheter, stop for a moment and think. Ask the patient, what's your experience been like prior? They can tell you a lot. That can help inform you whether or not they're a difficult to access patient. You can find out if they're extremely nervous, if they're fearful of the insertion. Maybe you can just do some distraction and talk to them. If it were my in-laws, you could talk to Betty about her jewelry or about, anything about her. She'll talk for endless, hours about that. So you could talk with them. And also, tell them why you're placing the peripheral IV catheter. And once it's placed, who to tell and what to tell them about if there is a complication. There's been many times where I've been either a patient or a family member by a bedside and there's a complication and the patient did not know, my family member did not know who to call and how to access help. And that could be very simple and it could be done during the insertion. And that way we know early on if there's a complication. And if nothing else, we're collaborating with our patient during insertion. Even if my in-laws forgot to say something after the insertion, they would have felt more comfortable understanding why this was being done and what was happening at the time.
And before we end today's episode, do you have any final thoughts?
So I guess my final message is that It may just be another peripheral IV catheter insertion for us or for you, but for the patient, it's much more than that. And just to keep that in mind in your next insertion. Thanks for having me, Derek.
Thank you so much, Dr. Steinheiser, for coming into the studio today to have this impactful conversation. And as always, I'm your host, Derek, and it's been a pleasure sharing this important discussion with you. Remember, knowledge empowers us to make informed decisions. Until next time, stay informed, stay curious, and keep gaining knowledge. Thank you for tuning in.
Infusion complete.